Hi, I'm Pete Davison. You've spoken in the past about each patient having a named doctor in charge of their care, and I think that's great. We run that system in our practice. It's fantastic. The buck stops with me. I think that's great. Now, I'm amazed that you didn't say anything about the big conference announcement, which was on all the papers this week, and all my patients are aware of, that I'm supposed to be opening 8 till 8. You said nothing about it in your speech, which I was a bit surprised by. It seems to me the only way you can fulfill both of these ambitions is to ask everyone in this room to work 84 hours a week so that they're available for their patients at the weekend. Now, I've done 84-hour weeks. I've worked 84-hour weeks. They're not safe. They weren't sustainable, and I'm not going back. I'm sorry.
Is that it, Pete?
It isn't. I'll come to the point. It seems to me you can have continuity or you can have access, but you can't have both. So you have to choose. Can you tell us which will you prioritise?
Yeah, no, I got the question.
Beth.
We've heard a lot today. I'm a GP hire, GP insurer and a GPC negotiator. We've heard a lot today about what GPs can do for their patients and the system. And I would like to ask you what you can do for GPs. I think what we need is contract stability. We need the funding, the resources, the extra GPs to help us deliver the quality care, the time to care, the time with our patients to actually do the things that we all want to do. What we don't need is to be told that we want to open longer, that we actually have resources which are not reoccurring and actually really worry GPs about the future. Can I ask you on behalf of general practice to deliver the funds and the extra GPs we need to make this work for our patients?
Thank you. I'm going to pick up the last two questions, number 3 and number 5, and then Jeremy, you'll have about 2 minutes to respond to the whole lot. Number 3. That's you.
It's simply about the limits to marketisation of the health service. I work in a GP practice Ashley Liston from Sunderland, North East. And my practice is an APMS contract. We bid for the PCT managed practice in 2006. We've been informed now that after the termination of this contract, we will have to bid again. I am an ordinary GP. I happen to run the practice as a partner. If I do not win the contract, and there will be a massive competition I expect, I'll be out of a job. I'm a local lead, GP tutor, an advocate for our locality and CCG supporter, an advocate for the community. Is there a limit to the marketisation in the health service?
Very good. Very patient. Sorry, number 3, there's not going to be time. Number 5.
My name is Rhiannon Nally. I'm a GP in Peterborough, near Peterborough. I just want to make a really fundamental point, and it'll echo some of the points made by colleagues just now. And that is that I think that there is a clear distinction that we need to make between access, which is something we've championed above everything else over the last years. We've had walk-in centres, we've had out-of-hours centres, we've had NHS Direct, and now we've got 111. Patients are confused about how to find a medical opinion that they can believe in. And I think that we've got mixed up about priorities. And I think that patients don't necessarily want 24/7 access to their GP and to people who can make decisions about them. What they want is a really good medical opinion, and they want to talk to somebody that will sort them out. And they'd like to do that in the first conversation that they have.
Thank you very much.
Not the 5th one.
First question by Francis. What can we not do if we're being asked to do more? And I think, I exactly recognise that. I think there is some mileage to giving you more time by looking at the less effective QOF targets. I don't think that will be enough to free up all the time that we need. And we have a challenge. I don't want, there's no hiding from the fact that although this government took the difficult decision not to cut the NHS budget, which in my last department we had a 24% cut, so every other department in government had a bigger cut in order to freeze the money going into the NHS, but it is a challenge. And so I think the only way that we're really going to solve this is if we can find a way where if you save the NHS money by more proactive care, some of the savings that you make for the NHS flows back into your practices.
We do save money for the NHS
Indeed.
Already.
So, well, thank you.
We save considerable money.
Well, I'm sure you're not arguing that you wouldn't like more money for doing more work to save money for the NHS. I think that's the only way that in the end we'll be able to resolve this. John's point about self-care, I completely agree. Why I want to think differently about different groups of patients. I think there's frail elderly, the most vulnerable, mainly older people. What they want is case management, proactive wraparound care. But for a diabetic in his 60s, what they want is self-care. That's much more cost-effective. That's a different model of care. That isn't, being in touch with them every day or every week, but it's helping educate them to look after themselves. And technology, I think, can have a huge role to play in that. And I think we need to explore that much more next year when we work out what is the way that we improve collectively the whole approach to long-term conditions. Pete's point about the announcement this week, for the 8-to-8 surgery, well, the fourth of those groups of people that I talked about, the normally well, people who are at work, they do prioritise. For them, access is something that's very important. And what I want to do is to understand what the costs are of improving access. When I was answering the phone in Claire's surgery, I had to, virtually everyone I spoke to was calling up, asking for an appointment, and in every single case I had to say, if it's urgent, you can come in tomorrow morning at 8 o'clock, otherwise I'm afraid it's 3 weeks before you get an appointment. Now, for most people that's not acceptable, and that in the end is what drives the people who want to go to A&Es and want to go to other parts of the system, when I think actually general practice is what we should be wanting to attract people to. So there was additional money with the announcement this week. And what we want to understand in these 9 pilot areas is some questions which I know is on a lot of people's minds. For example, does it take more time or does it save time if people can email a question to their GP? Now, many GPs here say that's going to create more workload as they get a flood of emails from people suddenly thinking that they can email their GP. But in the US, you find quite a lot of doctors who say the opposite. And we want to see in the UK context what the implications are to understand whether there's any potential in that. So I think it's worth exploring that and finding that out, and that's what the announcement this week was about. In terms of Beth from the GPC, I think we do need to get more money into general practice, into primary care. I think that is the thing that has failed to happen for over a decade now, and it's a question of finding a way that makes that work, and that's what I think, we need to have good discussions with the GPC to find out the best way of doing that. Ashley's question was about things being put out to contract. Well, the rules that CCGs have to operate under is that they only have to put something out to competitive tender if it is in the interests of patients. And I think it's really important that CCGs understand that is, if they don't believe it is in the interest of patients to do that, then they don't have to do that. And the final point, Rhiannon's point about access, I don't believe that, we do have a choice between access and continuity of care. I just think it depends on the type of patient. I think if you're a normally fit and healthy person, then you will want to have easier access to your GP, but you may be much more flexible about whether it's the same GP. If you're someone who's got complex long-term conditions, who's much older, then although you may not always see the same GP, it'll be very helpful to have, as it were, a controlling mind who's taking responsibility for your overall care package. And I think we need to try and find the right solution for all different groups of people.
Thank you, Jeremy. Thank you for the answers. I'm not 100% sure my conference are going to be spurred on, because there's no new money that's being announced other than 50 million for pilots, and I think I would urge you, and I think we have been talking, that actually we are at serious risk of destabilising the whole of the NHS. And of course we have to trade access and continuity, but you can only have 2 out of the 3 of access, continuity and affordability. And I think you are listening. you are listening, but I think it's really important that if we can, we put politics behind and we start looking at what is best for the NHS and our population and having a serious discussion about not just addressing the £400 million shortfall, but as I was announced, as somebody told me today, it's actually nearer £1 billion if you start to factor in all the other cost reductions that general practice have had over the last few years. So I would like to thank you. I think it's incredibly good of you to take time out and to come to us. And thank you for all your team for coming. So thank you very much.
Thank you.